Well, welcome to this next session of Q&A and our high tea. This is a pre-recorded session because what I wanted to do is just answer some of the questions that have been piling in over the last few months, where people have really begun to start using silver fluorides, and also answer some of the questions that came from the SOFACon that was held by EMS in April. Now, I've got a list of them here, so I'm just going to go through them, and they vary on usage and application and also manual handling. So I've tried to kind of put them in order, and so hopefully there'll be some sort of semblance of flow. They've come from all kinds of clinicians and from all kinds of spheres of use. So some of the clinicians are treating pediatrics, some are treating older patients, and of course a lot of them are in both public and private use situations. So for those of you who are familiar with the use of silver fluorides, there are my preferred method of using silver fluorides is the CSDS product, which is the Caries Status Disclosing Solution. And why I prefer that is because it is a water-based product and it has a pH of just 6.3. So therefore it can be left on the tissue and on the tooth for a really long time, and you don't have to worry about any of the effects of any ammonia-based materials that are in the product that could be damaging to the tissue. So when I'm talking a lot about the application, I'm talking about that in respect to the product that I prefer to use. And so, you know, if you're listening to this and you're not familiar with the CSDS product, then you'll be going, oh my gosh, you know, leaving it on for so long, you know, what about this and the gingival, you know, tissue burns and things like that? Would you get with a high ammonia product? Just don't worry about that. We're well aware of that, but in this circumstance with this product, we don't have to worry about it. Okay, so one of the questions came because oftentimes when I'm using CSDS, I talk about having a second application. Now, CSDS in its purest form means Caries Status Disclosing Solution. So when you put the material on the tooth and you find that it goes black and stays black, you know the caries is arrested. If there's an indication there that there's some brownish area still there when you get the patient back, it means that another application is warranted. Now, what are the indications, okay, for a second application? Well, one of them is the color change. So if you don't get a deep, deep black and it doesn't stay that color, then that is the warranted then a second application. The other thing that would mean another application would be if sensitivity, and particularly in the case of a hypermineralized tooth, if that has not completely resolved in the first application. Now that will depend on the extent of the hypermineralization. So if you have a tooth that is extremely sensitive, and that can be with or without post-eruptive breakdown. But oftentimes it's very difficult to get a very good application on the first round because the patient is very sensitive, and you're usually dealing with children, so puffing air on that tooth, and even in a caries situation, you know, if you can only get a cotton ball or a cotton pellet dry, you know, drying of the tooth without an air dry, okay, then that means that there will be more likely that you'll need to do a second application. And I find that particularly with hypermineralized teeth. They're very sensitive, the kids are really jumpy, and it's really difficult to put any air on the tooth. You don't even need to put a first application on. Just dry it with a cotton pellet, put the application on. The level of desensitization will be so great anyway, but it won't be complete. often, so therefore you need to come back. But by that time, the child has been so desensitized that you are able to puff some air on that tooth, and then you'll get a really great go the second time round. So that's the indications for the second application. So the question then was, how far apart would you apply silver fluoride if you do need that second application? Definitely, within a week is fine, because what you're doing is you're just loading more of the silver and the fluoride ions into that tooth. And in the case of CSDS, you're also putting the stannous ions in there as well. And so when you, I do them usually a week apart because it makes sense for the patients. Sometimes it can be 2, 3, 4 weeks apart. It doesn't matter. The longer that you leave it, the more likely that the tooth is beginning to remineralize anyway, particularly in the case of caries. But with hypermineralized teeth, I like to get that second application on in about a week, just for patient comfort. And then you can decide what you're going to do with that tooth for the ongoing maintenance of that, whether you're going to then move on to a GIC, either restoration or a GIC sealant. And again, in those cases, I use a high viscosity GIC, and the one I prefer is the Equia Fort, only because it's very high fluoride and very long wearing. And when you have prepared the tooth with the CSDS, you find that there is a very high retention rate with that material. So the second question, or the next question here was, would I recommend a 3-monthly application alternative with fluoride varnish? Now, I'm assuming here that they're talking about in the aged care population where there is a dry xerostomach mouth, and it's often very difficult to apply silver fluoride, particularly if you're using it in a nursing home situation. 3-monthly applications are great in that realm. And you won't need to do that forever. You would probably need to do that for probably 3 or 4 times. And by that time, the amount of remineralization and arrestation of any of the caries that may have been there has already occurred. What you need to remember, though, that oftentimes these patients continue to live in a very xerostomach state, and so even though you've got the advantage of having the silver in the tooth and it's already modifying the bacterial activity, the reapplication is of great benefit for the tooth, and it was one of those things that it's all very case sensitive and case selective, and you'll know the patient. If it's a child, 3-monthly applications you don't need to do, particularly with the CSDS, because if you're treating caries, then once you've got that arrested and whilst it stays black, then you know that you're fine. And fluoride varnish, yes. What I tend to do is I treat the tooth or the patient with the CSDS. Once I've established the arrestation of the caries, there is no progression, sensitivity is all dealt with, then I'll just keep going with the fluoride application at the general recall period. And I use a fluoride varnish for that. I'm a big fan of using fluoride varnishes. And so that to me gives you a greater uptake of fluoride in the site-specific areas that you need to have the fluoride. So I floss that in between the teeth routinely, but particularly if I've treated them with the CSDS as an interproximal remineralization material initially. Somebody asked the question about the fact that Rivastar had an indication that it shouldn't be used with folks with a thyroid condition. And they were wondering whether CSDS had the same implications. No, it doesn't. The reason being is that the Rivastar component, the part of that system has got potassium iodide, and so therefore that will be a contraindication for folks with the thyroid, because the CSDS product does not have that. Then you don't have to worry about that. Then they sort of said is that other contraindications. The same things apply with both products. You would not use it on somebody who has an allergy to silver. Very rare, but and it's not the silver jewelry kind of allergy. It's pure silver. You wouldn't use it for desquamative tissues. Now that pertains a lot because of the ammonia compound on some of them, but you just wouldn't use it anyway, just because you need to protect those tissues as they're going through the healing process. And the other thing too is you would not use it when people are really have a problem with the potential for staining. Now, I am very careful to guide my patients through the fact that there will be some staining, whether it be temporary or transitional or permanent. And I think it's really important to guide them through with that with the correct resources, which is why I've created the ARMA's resources and the chairside assistance, because then you can explain to them about the what things are looking like now, what it will look like, tomorrow or this afternoon, and then and how it will be looking at the end. And I call that a transitional stain. So it's one that is going to be there for a while until we deal with it. And then there's the more permanent staining, and that's if you are intending not to restore that tooth. And some people are fine with that, and it just depends. It's all very specific. If the patients are very, very young, that transitional stage may last for a long time, a couple of years. If they're very old and it's up the back or on the lingual surfaces of the anteriors and nobody's going to see it, they might be fine with that as well. But you do need to, I guess that's a contraindication you need to be aware of, but carefully explained, well explained, and having them fully consulted, you'll be fine with that as well. Now there's another question here which is a bit tricky. It's the differences in the effectiveness between CSDS and Revastar. Now I guess that depends on what you're using it for, because they are very different products. They were both designed for different purposes, and both of them are used differently in different realms. And I think that I can't really make a judgment on that. The pH and the very high pH of Revastar, because it's 13, and that was put in there for a reason, and it was put in there for the reason that the product was invented for. But how I'm using silver fluoride and how most of the public or most of the practitioners who are using it, it's particularly in the pediatric or the very aged care populations, would not be using Revastar for the purposes of doing what we're doing with it, which is, long applications, frequent applications, and keeping that on there for a long period of time. And so the effectiveness in the effectiveness is the longer that the tooth is exposed to the silver material and the fluoride, but particularly the silver in the initial stages, the longer that is exposed to that, the greater the depth of the bacterial kill, and the amount of success you're going to have in that realm with one application. So when you've got a product with an ammonia in it, you're limited to a short exposure, a minute or so. When you have a product that is more is water-based, so the pH is quite neutral, then you can leave that on for a really long time. So what I find is the effectiveness is, because we're putting the silver fluoride and we're adding the stannous fluoride, which those two things come together and actually have a better and more efficient bacterial kill, and then start the remineralization process. Now that in my mind, makes that more effective. And then I can safely put a holding material on that. I choose to use Durafat. There are other materials. You could use the oro-based paste, but to be honest, it doesn't taste very good to the children. And so the Durafat will kill the flavour of the silver fluoride quite well, actually. But you can hold that material there in place for ages. So I say to them, don't brush your teeth that night. You know, I'm giving you a gift of, this is the one night off that you don't have to brush your teeth. So that plug of Durafat is actually, apart from giving a little bit of fluoride, but it's also allowing the silver and the stannous ions and the fluoride ions to hang around in that site-specific area for a really long time. And that is where you're going to get an immediate change in the status of that tooth, from being very active caries to very inactive caries. And the fluoride then has the opportunity to start the remineralization process straight away. And because you've put the silver and the stannous fluoride together straight away, there becomes quite a change in the nature of the caries that has already been there, and it forms like a spongy a matrix. And what that does is it holds the fluoride down in there, so the fluoride then continues to remineralize. So that's why you can get that closer to the pulp of the tooth, and also you can have the remineralization held there for a long period of time. In that respect, yeah, I do believe that the effectiveness is much greater when you're using that product. Now, another question that was here is, why don't I use and talk about stainless steel crowns? Well, there's two reasons. One, because the only stainless steel crowns, that I was ever trained in was the traditional way, which was quite aggressive, and you needed to take away a lot of tooth tissue, and it flies in the face of minimal intervention dentistry. I have not done any training in stainless steel crowns in the whole technique. I could probably avail myself of that. But the thing is, I have such good results with putting GICs in. Now, if you're in the whole crown camp, great, but please, I still think using a silver fluoride as a pre-treatment for that is a really great idea, because it's going to mean that you are definitely knocking off that bacteria before you seal it off. So you're going to have a mental surety that you're not leaving any anaerobic bacteria that is active in there. I just think that particularly when things are quite deep, if you know that you've knocked off that bacteria, you've started some remineralization, and then you do crown the tooth, you're going to be streets ahead of those who are just placing the whole crown straight on, particularly if things are quite deep. Now, having said that, going back to my GIC use, because you are minimizing the size of the preparation that you need to do with the fact that you've remineralized so much of the tooth tissue, you're actually reducing the size of the GICs, and there's no two ways about it. The larger the GIC, particularly in a class 2 restoration, the weaker it is. But because you by doing the CSDS application prior as a pre-treatment, you've arrested that caries. You've got a really lovely hard base. When you do go to then place the GIC on, and it is a 2-stage technique, have I put silver fluoride on a couple of teeth where they have gone on and abscessed? Yes. How many? Probably a handful, and I've been doing this for 3.5 years. So there are very, very little, because, okay, even if the GIC is lost, you've remineralized that barrier between the pulp and the tooth, the outside of the tooth. And you've had a GIC on there, so it's as hard as a rock. So even if it's lost, it's a matter of either just replacing it or adjusting the occlusion and making it real, or the proximal box and making it really cleansable. And that will last the children right through. So yeah, it's one of those things that you're on in either camp, and it's fine. But that's the reason why I don't use the stainless steel crowns. And who's to say? I mean, I'm open to learning new things, and I might even do that. I've never had them available to actually try and practice with either. So that's probably another thing. So now we're getting to the manual handling side of things, and I had this question, and it was quite interesting. What happens, because silver fluoride and the CSDS silver fluoride is a two-part mix, what happens if it is dispensed in the wrong order? And so therefore you put part B, which is your stannous fluoride, on, and then you put your part A, which is the silver fluoride, on, and the stannous goes on for 3 minutes, and then the silver goes on for a minute. Now the question was, will it still go black? Yeah, it'll still go black, because the blackness is those two materials interact. The permanent blackness, okay, you would not be as successful with. Yes, so it will react the same way, okay, and it will go black immediately, but the likelihood of that tooth being successful is greatly reduced. So their part two of that question was, should they wash it all off and start again? I would. Now, one of the reasons is that if you ever cleaned up your silver fluoride and your stannous fluoride material, you'll notice that the stannous fluoride has got a little bit of like oily residue in there. So if you're going to put that on for 3 minutes and then you're going to put your silver fluoride on top, it's going to actually probably block the silver fluoride from getting through to the bacteria, which is where you want it. So I would wash it all off and start again. Now, to stop that from happening, there's a couple of things that I do. I make sure that our auxiliary staff are well trained. We have a protocol for using silver fluoride, and it basically eliminates anything from that to happen. Now, that protocol is available on the ARMA website. There is a manual handling video that is also available on the ARMA website. And so if you are going to start to use silver fluorides, my gift to you is to get onto the ARMA website, which is www.arma.com.au, and check out the videos, the application videos, but also check out the manual handling video, and get your staff to watch that, because the more people are familiar with how to handle this material, particularly if they've not used it before, the more they will respect it. And it's a lot easier to respect the use of this product than learn the hard way. And the hard way means you've got staining everywhere. So one of the things that we do at our practice is we keep our silver fluoride in a little container like this. Now, that means that everything is contained in there. So the two materials are contained in there. And I also keep some Dappin stitches. I'll show you that as well. They don't have to go in there, but it just makes it easier. So what I don't want is, I don't want these bottles sitting in a drawer and tipping over, and somebody picking up the wrong color and putting the wrong lid on the different, bottles and things like that, because people do that in a rush. And I certainly don't want it picked up and used as something else when it's silver fluoride. So we keep them together. Now, obviously the CSDS comes in these two little things. It's a red lid with a little red collar, and the white lid. Now the red lid is the silver fluoride, and this is the stannous fluoride. Now, I call them, well, this is part A and this is part B. Now, what I call them is, I call it red lid and white lid. So there is no mistake, okay, if you're sort of going, rather than call it stannous fluoride, silver fluoride, one of those two things, to people who are not really familiar with it, they don't mean very much. Part A, Part B is a little bit more descriptive, but red lid and white lid, totally descriptive. Now, what I also try and do is I have different coloured Dappens dishes, and I like to have a red and a white. Now, that's not always possible, but if you can get a green and a blue, or you know, a yellow and a red, or something like that, I keep the darker one for the red lid. So the dark lid goes in the dark Dappens dish, the white one goes in the light one. And it's just the way kind of we work, but definitely keep those two Dappens dishes, if you can, two different colours. If that's not possible at your practice, then what I do, if they're dispensed in something like this, I have these little guys here pre-marked. So what do you think this one will be? It will be Part A. It will be the silver fluoride, because it's the one that's going to have the ability to turn things black. So what they do is they put the silver fluoride in that one, they put the stannous fluoride in that one. And that's the kind of, you know, that's how you go about that. I also make sure that they are dispensed on my tray. And so when they are, my nurses are putting it out, they'll say, just putting the red lid out, or we're putting the Part A here. And then, so they're confirming and you're confirming that it's this particular dish is Part A and the other one is Part B. We've never, since we've started doing these kind of things, we've never had any accidents. We've never had any spills, and we certainly don't get them mixed up. Now, once they are used, the lid goes back on, okay? It's not overly tightened, but it is tightened. And then, of course, it just goes back into the container again. And then that just pops in the drawer. I just think that that's a safe way of doing it. You can get these little containers at Woolies for, like, I don't know, $5 or something. They're not very expensive. But we've got a couple of kits floating around in our clinic. We've got a 9-chair clinic, and I think we have 2 kits floating around. They mostly live in my room and the other OHT's room. But when people come in to borrow them or grab them, they just pick up the whole kit, and that makes a lot of sense to me. So yes, that's how I would recommend to correct that kind of thing from happening. And it's just about working it out. And you'll find something for your own practice, but be mindful about the use of and your protocols. The protocol that I've actually, the SOP that I've got on the website, is the only document that's in a Word form, so that you can actually apply that and change that to put your own practices identifiers on there for your own systems. Everything else is a PDF because it's all got a copyright on it. But those ones you can change to fit yourself a little bit, but it's a guiding start, okay? Yeah, so that's right. The advantage of having the silver fluoride there for the 3 minutes is that's the thing that is going to be the most effective part of it. The stannous fluoride is not as effective, but it works beautifully with the silver fluoride, but it's not the thing that is the overarching, what would you call it, active ingredient of these kind of things. So, okay, somebody asked about staining on the gingival margin, okay, because they had applied silver fluoride and they noticed that it had gone, because it's a liquid, it goes down around the gingival margin. And sometimes you see a white area on the gingival margin. That is not a burn when you're using CSDS. It is just where the silver has been absorbed into the skin. Now, it's not going, even if it does stain around there, that's going to come off. So you don't have to be worried about that at all. And when I say it's going to come off, usually it stains there and it looks quite manky. And I explain that to the patients. I say, look, when you go home and you look in the mirror, this is going to look really ugly, but don't worry about it. It's going to come off and it will brush off. But the longer you can leave that on, you know, today, the better off the tooth and the result is going to be. They're fine with that. So it's one of those things you don't have to worry about, but I would be certainly warning the patients about. Now, once this has been successfully applied, these questions came as people were beginning then to restore the tooth, which is great. So one of the questions was, what if I don't hear that cry-dentinere sound after removing the burnt toast? Okay, for those of you who are new to this game, cry-dentinere is the sound after you have prepared a tooth and you're cleaning the tooth and you've got a little excavator and you hear that kind of scratchy sound, and anyone who's a clinician knows what I'm talking about. That sound is called cry-dentinere. So once you have taken off what we nickname the burnt toast, so when you're going to restore that tooth, if you're able to get your slow speed burr in there and you're just cleaning off the burnt toast, and that comes off like it just sort of lifts off with a slow speed burr. You don't have to go and put pressure on there, and it's not a lot of preparation, but you're just removing the burnt toast, which basically is the dead cellular activity from the decay. So because decay is a bacterial activity and there was a lot of initial caries, active caries that you have there that you've now killed off. So this then looks like burnt toast. And then underneath that is where I guess we would have called that affected dentine is now remineralized dentine, and you often then hear this cry-dentinere. If you don't hear it, it's okay. It's just one of those things that you know, it's great with the kids. You know, when you're taking off the burnt toast and you say, "Oh, listen to that! Can you hear that scratchy sound?" You know, then what that is the cry-dentinere. So if you don't hear it, don't worry about it. But you'll feel what once was we would have thought as like a leathery kind of affected dentine is now quite hard. So that's fine. The other thing you'll need to know is that when you take an X-ray at your recall visits, you will still see that affected caries, and it will look like it is caries, but it's not. It is remineralized dentine. Remembering that caries is an active process. It's a bacterial activity. Once you have stopped that and you have remineralized the dentine, it is no longer carious. It is a remineralized dentine, and it will appear in the X-ray under a filling as though it has recurrent caries in it. That is why it is very important to give your patients the post-treatment cards, the ones that will tell them, and I'll show you one of those, because it explains to the patient, okay, well, basically to the patient and the next clinician, that this is what has happened, because the patients will probably forget. But if they go there and the dentist sort of says, "Oh, look, under this you've got some extra, you know, dentine, you've got some extra caries or whatever, we have to replace that filling," that will trigger the memory, because I explain this to the patients and I say, when somebody takes an X-ray, if it's not me, and they see this dark area under the filling, this is going to, people are going to think that this is caries, but it's not. So you have to be most careful about it. And I get them to have a look at the ARMOR approach. We go through that with them as well. Particularly very important when you're dealing with permanent teeth. And I use this a lot in permanent teeth, but the parents, the patients are well educated, and I show them the before and after X-rays, and I make sure that they're well aware of that. And the other thing that I would do for clinician, and I say to the parents too, I say, if anyone wants to take out this filling and drill this tooth, I want you to get the previous X-rays, because they will be surprised. And so it's, you know, the more you reiterate that, the better off. But the thing is, you've conserved so much of the tooth that people are prepared to sort of keep that in the back of their mind. And the other thing was, what is the time frame for taking a bite wings after the using CSDS or sulfur for interproximal caries? All right, so you've identified that there is a lesion, and the lesion is often interdentine, not hugely so, but it's amazing how much interdentine with CSDS that you can arrest and have no breakdown. And I've got 2-year studies, 2-year case histories, where most people would have gone and filled the tooth. But so I apply that, okay, and then and if you really want to see how effective it is, go back to the very first video that we did on our Q&A session, and it shows you an exfoliated tooth, and it's just quite remarkable. But anyway, getting back to the question, so I put that on. At the 6-month recall, I'll have a look at the tooth, and there's no marginal breakdown. I don't go and take an x-ray then. I then wait, and I take an x-ray at the 12-month mark. 12 months is good, otherwise you're over x-raying, because if you haven't got any breakdown in the 6-month marginal ridge time frame in 6 months, you're not going to get any, but it's good to have those follow-up x-rays. Now, just say you did have some marginal ridge breakdown, then what that means is you've arrested the caries, but the top of the tooth, the unsupported enamel has broken through. You just need to restore it. You don't have to repeat it unless you wanted to repeat the CSDS application, but you can just simply go on then and do a restoration. Or if you like, if you wanted to, you can pop a stainless steel crown on. But it's one of those things that it doesn't mean that the CSDS has failed. What it means is that the enamel was unsupported enough that it broke down, and can be a bit of a food trap. So just deal with that as you would normally. But it does not mean you have to go and do a pulpotomy on that tooth because the marginal ridge is broken down, because that, basically that doesn't happen anymore, not in my world. So okay, well, I hope that this has been helpful to some of you. I hope that your journey into silver fluorides is still continuing to grow, as mine is. I have been working with a lady who is nearly 70, and what we're doing with her posterior molars with silver fluorides at the moment is quite incredible, as far as mitigating her root surface caries and her perio conditions. So I won't get into that until I've got a little bit more work up, but it's exciting. So it's just the nature of the antibacterial side of things, and we're getting some really interesting results. But anyway, we'll get back to that another time. But I really want you to continue your journey with silver fluorides. Use it for the bacterial control. Use it for sensitivity, and use it to keep kids out of GA and to just preserve their tooth tissue. It's been a really, really lovely journey for me, and it's been great being able to do these kind of videos and show you where we've been coming from and bring a few other experts in along the way. So I'll sign off now and let you all get back to work and enjoy your experience with using silver fluoride. And if you have any other questions along the way, send me an email to the ARMA website, Kathy, which is CATHY @arma.com.au, and we'll get back to you. Okay, thanks so much. Bye.